Could you start, sir?
Yes. Good morning, all. Welcome you all to today's session of MRB Hackathon. So I hope you would have enjoyed the quiz, and I could see an enormous response from all of you. So how you feel the questions? So these questions are typical MRB Tamil Nadu MRB pattern. These typical MRB questions, Tamil Nadu will be like this. In the modern typical MRB questions. So you would have attended the questions. Now, now we'll go to the discussion. Okay. So we'll see the first question. First question, which of the following stain and the material stained by it is incorrect? So, which is incorrect in Kekranga. So, right, one incorrect. Pearl stain, iron, correct. Yes, pearl stain, pearl's Prussian blue, hemosiderin, that is correct. And leave about the other option. Copper and copper associated protein is rhodamin was the correct answer. Elastin and Van Giesen. Yes, elastin fibers with the Van Giesen will be the special stain for elastic fibers. Collagen. The special stain to highlight collagen is Mason trichrome. Okay. Collagen வந்து Mason trichrome will be highlighting in blue in color. So Mason trichrome போட்டிங்கன்னா collagen fibers will be staining blue in color. Vancosa வந்து எதுக்கு special stain? Yes. It is calcium. It is calcium. So Vancosa is the special stain for calcium. So this is the wrong option. So we have to choose this thing. So next question pathina, irreversible injury in myocardial infarction. Irreversible injury in myocardial infarction is due to or occurs within. Myocardial infarction occurs within. So, myocardial infarction, what type of necrosis, if somebody asks, definitely you will be writing that it is a coagulative necrosis. So, irreversible injury in the death of your tissue which cannot be replaced, that is, which can be reversed back. So, average time 30 to 40 minutes the door to needle time. So, door to needle time, that is should be 30 to 40 minutes. 30 to 40 minutes to மேல நம்ம thrombolytic therapy start பண்ணா, again it would have gone for irreversible injury. So the time period ideally is 30 to 40 minutes. So inga 30 option illa, 30 minutes and option illa. So we'll be choosing it as 40 minutes. So irreversible injury. So irreversible injury features questions also can be asked. So please remember 3 nuclear changes which I always used to insist: pycnosis, karyolysis, and karyopexis. So this will be the irreversible nuclear changes and flocculant, amorphous flocculant densities in mitochondria. That is also a change in the irreversible change which can occur in a myocardial infarction. Then another question pathina, all of the following are true about telomerase except. So telomerase we have discussed a lot. So telomerase enzyme enga nam pathina, normally tip of the chromosomes la, telomeres will be the DNA sequences, tip of the chromosome la DNA sequences the telomeres. So every cell division agumbodhu, the telomere length will be shortened. So after some 60 to 70 cell divisions, the cell stops its division. Certain cells, germ cells, stem cells, and your cancer cells will have excessive telomerase activity. So cell division will be constantly occurring in these areas. So in the telomerase enzyme, it is an RNA dependent DNA polymerase. RNA dependent DNA polymerase. Yes, telomerase expression in the germ cells, stem cells, cancer cells. This is responsible for the in the cells or the longevity. This telomerase enzyme is needed. Yes, and definitely the telomerase in the enzyme telomeres or the length வந்து shorten agama, it is actually maintaining. So idum correct option. Telomeres maintain the telomerase maintains the length of chromosomes by maintaining the telomeres. Yes, idum correct da. Telomerase has nothing to do with DNA repair mechanism. So telomerase enzyme is not involved in the DNA repair mechanism. So this is the wrong option we have to choose. Okay, this is the wrong option we have to choose. Complete wound strength is gained by. So this is a very important question, and MRB la pathina wound healing வந்து ஒரு important topic. Frequent MRB la wound healing பத்தி ஒரு question usually we can expect. So wound healing actually it is mainly by, as you all know, it is mainly by two intentions. Wound healing can occur by two mechanisms, either by wound healing by primary intention or wound healing by secondary intention. Yes. So ஒரு surgery where you have lot of aseptic precautions எல்லாமே follow பண்ணி, and when there is a clean wound, surgical wound, இந்த மாதிரி areas heal ஆகிற wound is heals by primary intention. When there is a lot of loss of tissue loss, chance of infection, contamination, the wound will heal by wound healing by secondary intention. So main mechanism there will be blood clot formation and blood clot first varum. So adukapram enna varum, neutrophil cells will come and destroy all those blood clot and will eat away all these things, and then this will be followed by macrophages and granulation tissue. So in the granulation tissue வந்துச்சுனா தான் உங்களுக்கு வந்து wound healingல அந்த fibroblast வந்து collagen வந்து produce பண்ணும். So fibroblast will produce collagen, and the collagen only is responsible for the scar tissue. So என்னதான் fibroblast, collagen, scar tissue வந்தா கூட maximum actually பாத்தீங்கன்னா complete wound strength வந்து 3 monthsல வந்து you can get maximum wound strength, that too only 70 to 80% வந்து maximum you can get it. You can never get a 100% strength. 100% strength a wound will never get. The maximum strength a wound can get is 70 to 80%. Adum 3 months la actually it will be obtained. So the answer in the question answer pathina never regained. A complete wound strength will never be regained, whether it is by primary intention or secondary intention. Eppadi andalum it will never be regained. Then this is a very important repeat question. Metastatic calcification is seen in all except. Yes, all of you are aware what is metastatic calcification. So metastatic calcification na enna, the calcium levels in the body வந்து high-ஆ இருக்கும், hypercalcemia. So there will be hypercalcemia. So on the excess calcium, the excess calcium will be deposited in a live tissue. Excess calcium will be deposited in a live tissue. The commonest tissue pathina gastric mucosa, kidney and lung. In the many tissues in a live tissue excess calcium will be deposited. That is metastatic calcification. If you pathina multiple myeloma hypercalcemia will be there. All of you will be knowing this. All of you will be knowing that multiple myeloma there will be CRAB criteria. CRAB criteria you would have heard hypercalcemia, renal failure, anemia, bone lesions. So CRAB la hypercalcemia வந்து multiple myeloma la இருக்கும். So hypercalcemia multiple myeloma la இருக்கும். Sarcoidosis la hypercalcemia is always an important feature. Sarcoidosis and renal failure also hypercalcemia will be there. But in atherosclerosis, atherosclerosis, it is a dead and degenerative tissue. The degeneration change with the so calcium levels வந்து நார்மலா தான் இருக்கும். So எந்த ஒரு இடத்துல dead tissue இல்ல ஒரு degeneration, ஒரு injury ஆன இடத்துல calcium levels நார்மலா இருக்கும்போது அந்த calcium வந்து deposit ஆகும்போது you call that as dystrophic calcification அப்படினோ. So dystrophic calcification calcium levels வந்து நார்மலா இருக்கும், but because of the degenerative change and the calcium வந்து deposit ஆகும். Atherosclerosis is an example of dystrophic calcification. Dystrophic calcification. Okay. So also please remember the somoma bodies இதெல்லாம் நீங்க படிச்சிருக்கீங்களா, papillary carcinoma, that is an example of dystrophic calcification. Dystrophic calcification. Now moving to the next question, that is what is the most common cause of Down syndrome? So Down syndrome question you can expect in your exam. So Down syndrome, please remember the most common genetic cause of mental retardation. Yes, Down syndrome is the most common cause of genetic cause of mental retardation. So என்ன cause இதுல எது genetic commonest cause எதுனா all of us know that increased maternal age. So maternal age அதிகமாகும் போது என்ன ஆகும்னா the first common cause is meiotic non-disjunction. அதாவது nearly 95% of the Down syndrome பாத்தீங்கன்னா that is occurs because of the meiotic non-disjunction. அதாவது meiosis அப்ப the gametல usually அந்த 2 although the gametலயும் actually there will be, see, this is how, see, 21 chromosomes will be 2 in number, okay, in males and well as in females. So அப்போ ஒரு gamete இப்போ இங்க பாத்தீங்கன்னா மேல்ஸ்ல இருந்து வரதுல ஒரு gametல 21st chromosome இருக்கும், இன்னொரு gametல 21st chromosome இருக்கும். So but இங்க என்ன ஆகும் அப்படின்னு சொல்லிட்டு பாத்தீங்கன்னா ஃபீமேல்ஸ்ல சம்டைம்ஸ் இந்த ஃபீமேல்ஸ் ஏஜ் ஆகும்போது ஃபீமேல்ஸ்ல என்ன ஆகும், ஒரு gametல வந்து you will be getting 2 numbers, 21 chromosome வந்து 2 numbers ஒரே gametல வந்துடும். இன்னொரு gametல there will not be 21st chromosome at all. இன்னொரு gametல 21st chromosome இருக்காது. So when there is a fusion of these 2 gametes, then you will be getting 3 number of 21 chromosomes. 21st chromosome 3 number இருக்கும். Okay, so இதுதான் வந்து meiotic non-disjunction வாங்க. Meiosis அப்ப the 21st chromosome equal-ஆ பிரியாது gametல. இதுதான் most common cause of Down syndrome. ஓகேவா? Second most common எது அப்படின்னு சொல்லிட்டு பாத்தீங்கன்னா Robertsonian translocation. So Robertsonian translocation அப்படின்னா என்னன்னா acrocentric chromosomes. Acrocentric chromosome. See here, acrocentric chromosome இப்படிதான் இருக்கும். ஒரு ஷார்ட்டா ரொம்ப ஷார்ட்டா இருக்கும் and you will have a long arm. So என்ன ஆகும் அப்படின்னு சொல்லிட்டு பாத்தீங்கன்னா டிரான்ஸ்லோகேஷன் வந்து பிரேக் வந்து இங்க நடக்கும். So 2 ஷார்ட் ஆர்ம் சேர்ந்தது வந்து ஒரு குரோமோசோம் ஆகும் and பெரிய 2 ஆர்ம்ஸ் 2 லாங் ஆர்ம்ஸ் சேர்ந்தது வந்து இன்னொரு குரோமோசோமாவும் மாறிடும். யூசுவலா இங்க இருக்கிற அந்த சின்ன குரோமோசோம் ரெண்டுமே ஷார்ட் ஆர்மா இருக்கக்கூடிய அந்த குரோமோசோம் will be lost. வெறும் இந்த குரோமோசோம் மட்டும்தான் பெர்சிஸ்ட் ஆகும். சோ இந்த மாதிரி டிரான்ஸ்லோகேஷனை தான் நாம ராபர்ட்சோனியன் டிரான்ஸ்லோகேஷன் அப்படின்னும். சோ ஃபர்ஸ்ட் காஸ் வந்து பாத்தீங்கன்னா மியோட்டிக் நான் டிஸ்டங்ஷன், செகண்ட் காஸ் பாத்தீங்கன்னா ராபர்ட்சோனியன் டிரான்ஸ்லோகேஷன். The last cause என்ன அப்படின்னு சொல்லிட்டு பாத்தீங்கன்னா அதுதான் மொசைக்கிசம் அப்படின்னு சொல்லிட்டு சொல்லுவாங்க. மொசைக்கிசம் அப்படின்னா மொசைக் பேட்டர்ன், அதாவது பேஷண்ட்டுக்கு அந்த டவுன் சிண்ட்ரோம் இருக்க பேஷண்ட்டுக்கு சில குரோமோசோம் சில செல்ஸ்ல they will be having 46 chromosome. Some cells will have normal number of 21 chromosomes ரெண்டு இருக்கும், அதனால 46 chromosomes இருக்கும். Some chromosomes, some cellsல பாத்தீங்கன்னா 47 chromosomes இருக்கும், அதாவது trisomy 21 சில செல்ஸ்ல மட்டும்தான் இருக்கும், சில செல்ஸ் நார்மலா இருக்கும். சோ மொசைக் பேட்டர்ன் அப்படின்னா நார்மல் செல்ஸும் இருக்கும், 46 chromosomes இருக்கக்கூடிய நார்மல் செல்ஸும் இருக்கும், 47 chromosomes இருக்கக்கூடிய trisomy 21 செல்ஸும் சேம் பேஷண்ட்ல ரெண்டு செல்லுமே கலந்து இருக்கிறதா மொசைக்கிசம். Like that we will say. So mosaicism the least common cause of Down syndrome. Okay, so for the first common cause, most common cause என்னன்னு பாத்தீங்கன்னா meiotic non-disjunction. Meiosis அப்ப equal-ஆ பிரியாது. This is the reason. Okay. Now, moving on to a very important concept, that is the basic concept in neoplasia, lack of differentiation. Lack of differentiation is called. What do you mean by differentiation? Differentiation அப்படின்னா என்ன நியோப்ளேசியால பாத்தீங்கன்னா ஒரு டியூமர் டிஷ்யூ எந்த பேரண்ட் ஆர்கன்ல இருந்து எந்த டிஷ்யூ ஆஃப் ஆரிஜின்ல இருந்து அரைஸ் ஆகுதோ அதே டிஷ்யூவை மாதிரி ரிசம்பிளன்ஸ் கொடுக்கிறது தான் that is called as differentiation. If you say for example thyroid cancer, if the thyroid cancer, that is say for example follicular cancer, resembles the follicles or the normal thyroid follicles will be there in follicular carcinoma, you have that is well differentiated, that is the tumor is differentiation irukku. You can say that this is arising from thyroid parent tissue madri some resemblance in this, you call that as a well differentiated. Poorly differentiated abina enna, you can't identify which cell it is. அது ஸ்குவாமஸ் செல்லான்னு சொல்ல முடியாது, இல்ல அடினோகார்சினோமாவான்னு சொல்ல முடியாது, இல்ல நியூரோ எண்டோக்ரைனா, இல்ல மெலனோமாவா, லிம்போமாவா, நம்மளால எந்த ஒரு கன்க்ளூஷனுக்குமே வர முடியாம ஒரு பிசார் அப்பியரன்ஸ், ஒரு பிக் செல்ஸ் வேர் யூ cannot ஐடென்டிஃபை எந்த செல் ஆஃப் ஆரிஜின் நம்மளால ஐடென்டிஃபையே பண்ண முடியலனா that you call it as a poorly differentiated. So anaplasia அப்படின்னா என்னன்னா, that is one step ahead of poorly differentiated. That is, even you can't say what cell it is. Okay, there is not even a single clue கூட இருக்காது இது எந்த டிஷ்யூல இருந்து அரைஸ் ஆச்சுன்னு சொல்லிட்டு. டியூமர் டிஷ்யூ ஃபுல்லாவுமே big cells இருக்கும். That is called as anaplasia, lack of differentiation. You cannot identify எந்த tissue of originல இருந்து இந்த டியூமர் வந்ததுன்னு. This property is called as anaplasia. So generally என்னன்னு பாத்தீங்கன்னா, anaplasia is actually tells you that the tumor is having poor prognosis. ஏன்னா that tumor has come far away from the normal. Okay, so அங்க வந்து பாத்தீங்கன்னா the tumor tissue is coming far away from the normal. So poorly differentiated tumors and anaplastic tumors carries very poor prognosis. You can remember the example, anaplastic carcinoma of the thyroid. Anaplastic carcinoma of the thyroid, one of the aggressive tumor. So aggressive tumor, poor prognosis, anaplasia. There is no evidence of which tissue it is coming from. Okay. So metaplasia, unga ellarkum theriyum, metaplasia na conversion of one cell to another. Conversion of one cell to another. So that cell can be an epithelial cell avum irukkalam illa mesenchymal cells avum irukkalam. Then the next one is dysplasia. Dysplasia na disordered growth. அதாவது that is the epithelial cells, the cells will be showing dysplastic features. அப்படின்னா என்னன்னா, செல்லோட நியூக்ளியஸ் பெருசா இருக்கலாம், ஹைப்பர்குரோமேஷியா, டார்க்லி ஸ்டெய்னிங் நியூக்ளியஸா இருக்கலாம், இல்ல நியூக்ளியஸ் அண்ட் சைட்டோபிளாஸ்மிக் ரேஷியோ வந்து ரொம்ப அதிகமா இருக்கும். அதாவது this will be showing the features of malignancy. Dysplasia just tells you that இந்த cells normala illa, there is some atypical features, the cell nucleus is not normal, it is showing some atypical features. இதெல்லாம் only you are calling it as dysplasia. Okay, so carcinoma, all of you will be knowing that when there is an invasion metastasis இருக்கும்போது death dysplasia plus invasion metastasis இருக்கும்போது you call it as a carcinoma. Okay, yes, the next question is, which one of the following is not an example of paraneoplastic syndrome? Not an example of paraneoplastic syndrome. So paraneoplastic syndrome, all of you will be aware. Yes, what you thought of for this question? Paraneoplastic syndrome, all of you are aware that is not due to the direct effect of the tumor. Okay, paraneoplastic syndrome வந்து டியூமரோட direct effect இல்ல. டியூமர் ப்ரொடியூஸ் பண்ற ஒரு டியூமர் and the tumor cells produce பண்ற ஹார்மோன்ஸ் இல்ல பெப்டைட்ஸ், அதனால வரக்கூடிய symptoms தான் is called as paraneoplastic syndrome. So it is not due to the, please remember, not due to the direct effect of the cancer, but cancer produce பண்ணக்கூடிய, cancer cells produce பண்ணக்கூடிய ஹார்மோன்ஸ் பெப்டைட்ஸ்னால வரக்கூடிய symptoms தான் you are calling it as paraneoplastic syndrome. So இப்போ இங்க பாத்தீங்கன்னா first syndrome என்ன அப்படின்னு சொல்லி பாத்தீங்கன்னா Cushing syndrome. In a case of small cell carcinoma of the lung, so உங்களுக்கு தெரியும் small cell carcinoma of the lungல தான் lot of paraneoplastic syndromes இருக்கும். ஏன்னா the small cell carcinoma of the lung will produce lot of hormones. Okay, hormones. So when the cancer cells produce lot of ACTH, okay, adrenocorticotropic hormone, when it is producing lot of ACTH, definitely என்ன ஆகும், the patient will be having Cushing syndrome. So Cushing syndrome is not due to the direct effect of the cancer, but because of the hormone elaborated by the cancer. So Cushing syndrome, small cell lung carcinoma, is because of ACTH. And Lambert-Eaton myasthenic syndrome, இதுவும் வந்து actually ஒரு paraneoplastic syndrome தான். Small cell carcinoma you will be getting because of immune mechanisms, not due to the direct effect of the cancer. Some small cell carcinoma will liberate ADH, okay, antidiuretic hormone. So excess when ADH, antidiuretic hormone, is produced in the body, patient may have SIADH, syndrome of inappropriate ADH secretion. இதுவும் பாத்தீங்கன்னா not due to the direct effect of the cancer. So by A, B, C, D எல்லாமே வந்து due to the paraneoplastic syndrome. But regional lymphadenopathy எதனால வந்து metastasis நால வந்து. So metastasis is due to the direct effect of the cancer. Metastasis is due to the direct effect of the cancer. So metastasis direct cancer nala varudhu and adanala it is not a paraneoplastic syndrome. Okay. So coming to this question, so what are all the which one of the following is not a tumor suppressor gene? Yes, all of you is very important as well as a basic concept you should know. Two genes we have to know. One is oncogenes, that is proto-oncogenes, and other one is tumor suppressor genes. Body la pathina எப்போதுமே proto-oncogenes, okay, proto-oncogenes எப்போதுமே பாடியில ஒரு inactivated stateல தான் இருக்கும். Inactivated stateல தான் இருக்கும். Tumor suppressor gene எப்போதுமே ஒரு active stateல தான் இருக்கும். So because tumor suppressor gene ஓட வேலை என்ன? It should suppress the tumor formation. Tumor suppressor gene என்ன பண்ணணும்? It should suppress the tumor formation. Oncogenes should be normally inactive and tumor suppressor genes should be normally active. அப்ப mutation ஆச்சுனா, when there is a mutation ஆச்சுனா என்ன ஆகும்னா tumor suppressor genes will be inactivated. நார்மலா ஆக்டிவா இருக்கக்கூடிய அந்த tumor suppressor gene மியூட்டேஷன்னால inactivate ஆயிடும். நார்மலா inactiveஆ இருக்கக்கூடிய proto-oncogenes mutation வந்துச்சுனா again it will be resulting in oncogene or cancer formation, that is activation will be there. So ultimate end result என்னன்னு பாத்தீங்கன்னா cancer formation. So அப்போ ஒரு cancerல tumor suppressor genes will be in an inactivated state and oncogenes will be in an activated state. So commonest tumor suppressor genes, definitely all of us should know. WT1. WT na, it is Wilms tumor. Okay, Wilms tumor suppressor gene. That is also a tumor suppressor gene. RB gene, retinoblastoma gene. P53. P53 தான் நம்ம என்ன சொல்லுவோம்? Guardian of genome அப்படினோ. Okay, P53 a guardian of genome. So WT1, RB, retinoblastoma, P53 மூணுமே tumor suppressor gene. And RAS பாத்தீங்கன்னா, RAS is actually a oncogene. You must have heard KRAS mutation, NRAS, all these things. So RAS with the oncogene mutation. One additional point தெரிஞ்சுக்கோங்க, WT1 is in chromosome 11. Retinoblastoma எந்த chromosome? Retinoblastoma gene, RB gene எந்த chromosome? Yes, anybody can tell me? RB gene is in which chromosome? Can put it in the chat box. RB gene is in chromosome 13. RB gene is in chromosome 13. P53 எங்க இருக்கும்? எந்த chromosome இருக்கும்? P53 very important, no? We should not miss that. P53, yes, very good. P53 is in chromosome 17. Chromosome 17. Again, RAS is also in chromosome 11. RAS is also in chromosome 11. So at least the most important tumor suppressor gene in the chromosomes, please remember that. Okay, this is very essential. The next question is mutation in Marfan syndrome. Yes, what did you mark for this? Mutation in Marfan syndrome. So mutation Marfan syndrome la pathina, actually it is fibrillin 1. Mutation in the Marfan syndrome is fibrillin 1. So Marfan syndrome la we have to know that in the fibrillin oda function enna அப்படினு சொல்லிட்டு பாத்தீங்கன்னா, this fibrillin is more responsible for this microfibril environment. ஒரு டிஷ்யூல, கனெக்டிவ் டிஷ்யூல அந்த மைக்ரோஃபிப்ரில் என்விரான்மெண்ட்ல you will have this fibrillin material. So என்ன ஃபங்க்ஷன் இந்த ஃபிப்ரிலினுக்கும் இந்த மைக்ரோஃபிப்ரிலுக்கும் என்ன ஃபங்க்ஷன் அப்படின்னு பாத்தீங்கன்னா, இங்க மைக்ரோஃபிப்ரில் இந்த பேக்ரவுண்ட்ல தான் body will be laying down elastic fibers. So நம்ம பாடியில அந்த கனெக்டிவ் டிஷ்யூல இருக்கக்கூடிய அந்த எலாஸ்டிக் ஃபைபர்ஸ் ஒரு டிஷ்யூல லே டவுன் ஆகணும்னா there you should need microfibril environment. அதுக்கு fibrillin தேவை. So இந்த elastic fibers எங்கெங்கெல்லாம் இருக்கலாம்? blood vesselsல இருக்கலாம், ligamentல இருக்கலாம், even zonules of lens. So இந்த மாதிரி ஏரியாஸ்லாம் you will have lot of elastic fibers. So அப்படியே remember பண்ணிக்கோங்க, Marfanஸ்ல என்ன ஆகுது? fibrillin சரியா ப்ராப்பரா இல்ல. So again you have இந்த vesselsல ப்ராப்ளம் இருக்கு, லென்ஸ்ல ப்ராப்ளம் இருக்கு, subluxation and connective tissueல ப்ராப்ளம் இருக்கு. So fibrillin 1 actually microfibril, that is elastic fibers. So இன்னொரு MCQ here இங்க பாத்தீங்கன்னா ரெண்டு டைப் ஆஃப் fibrillin இருக்கு. Fibrillin 1 mutation தான் will be resulting in Marfan syndrome. Marfan syndrome. So fibrillin 1 is in chromosome 15. இது ஒரு MCQ. Marfan syndrome ல பாத்தீங்கன்னா chromosome 15. Fibrillin 2 is in chromosome 5. Fibrillin 2 is in chromosome 5 and deficiency or mutation in fibrillin 2 results in a condition called as congenital contractural arachnodactyly. Arachnodactyly. So related things இது note down பண்ணிக்கோங்க. Okay, mutation. Fibrillin 1 தான் Marfan syndrome. Marfan syndrome. Okay. So moving on to the next question is the any examiner's favorite question. Tissue of origin of Kaposi sarcoma. Yes, Kaposi sarcoma nale what you will be remembering? It is an AIDS defining malignancy. What is that AIDS defining malignancy? I used to tell, if a HIV patient presents with any of the three malignancies, then you can label in the patient AIDS stage ki poitanga அப்படின மாதிரி. A HIV patient, when he is presenting with any of the three malignancies, we can label them that they have gone for a state of AIDS. What are the three malignancy? One is Kaposi sarcoma. ரெண்டு வந்து primary CNS lymphoma. Primary CNS lymphoma. Third one is, which one is the third one? Invasive carcinoma of the cervix. Invasive no Manigandan, it is invasive carcinoma of the cervix. Okay, not lobular carcinoma. So in the moon தான் வந்து AIDS defining neoplasm. So in the moon tumors are called as AIDS defining neoplasms. So அதுல எது more common அப்படின்னு கேட்டீங்கன்னா Kaposi sarcoma தான். So Kaposi sarcoma தான் இந்த மூணு டியூமர்ல most common type, or most common tumor. So Kaposi sarcoma caused by HHV8. HHV8 அப்படின்னா human herpes virus 8. And please remember, in the Kaposi sarcoma, actually it is a tumor of the blood vessels. Sarcoma பேர் இருக்கு. Kaposi sarcoma போது it is mainly tumor of the blood vessel in origin. Blood vessels. So patient பாத்தீங்கன்னா trunk and also limbs எல்லாம் he can present with ஒரு reddish patch இல்ல plaque. So அந்த மாதிரி ஒரு erythematous lesion patient will be presenting. So Kaposi sarcoma is a vascular lesion. Vascular lesion. Okay. Then the next question, free radicals or the question definitely you can expect, basic thing. So enzyme that protects the brain from free radical injury. Free radicals, oxygen free radicals, enna mono oxygen free radicals, you will be knowing that mono oxygen free radicals irukku enna superoxide, hydrogen peroxide, innone enna hydroxyl ions. Hydroxyl ions. இதுதான் ஆக்சிஜன் ஃப்ரீ ரேடிக்கல்ஸ், அதாவது ரியாக்டிவ் ஆக்சிஜன் ஸ்பீஷீஸ் அப்படின்னுவாங்க. ஆக்சிஜன் ஃப்ரீ ரேடிக்கல்ஸ் இருக்கும். ஸோ இந்த ஆக்சிஜன் ஃப்ரீ ரேடிக்கல்ஸ் கேன் ரெஸ்பான்சிபிள் ஃபார் த கேன்சர், அத்திரோஸ்க்ளரோசிஸ், ஏஜிங் அண்ட் லாட் ஆஃப் டிசீசஸ் இன் அவர் பாடி. ஆக்சிஜன் ஃப்ரீ ரேடிக்கல்ஸ். ஸோ இந்த ஆக்சிஜன் ஃப்ரீ ரேடிக்கல்ஸ்ல இருந்து நம்ம பாடியை ப்ரொடெக்ட் பண்றதுக்கு தான் ஆன்டி ஆக்சிடென்ட்ஸ் வில் பி தேர். ஆன்டி ஆக்சிடென்ட்ஸ், அதாவது ஃப்ரீ ரேடிக்கல்ஸ். இந்த ஃப்ரீ ரேடிக்கல்ஸ் எல்லாம் பாத்தீங்கன்னா அவுட்டர் ஆர்பிட்ல, இந்த ஃப்ரீ ரேடிக்கல்ஸோட அவுட்டர் ஆர்பிட்ல ஆல்வேஸ் ஒரு அன்பேர்டு எலக்ட்ரான் வந்து இருக்கும். ஒரு அன்பேர்டு எலக்ட்ரான் வில் பி தேர். சோ இந்த ஆன்டி ஆக்சிடென்ட் என்ன பண்ணும், அந்த எலக்ட்ரான் quench these free radicals. எலக்ட்ரான் வந்து டெபிசிட்டா இருக்கும், ஒரு அன்பேர்டு எலக்ட்ரான் இருக்கும். So they always need of an electron, electrophilic nature, free radicals. So நம்ம ஆன்டி ஆக்சிடென்ட்ஸ் என்ன பண்ணும், அந்த ஃப்ரீ ரேடிக்கல்ஸ்க்கு அந்த எலக்ட்ரானை கொடுத்து அதோட தேர்ஸ்ட quench பண்ணும். ஸோ இப்படிதான் ஆன்டி ஆக்சிடென்ட்டோட வேலை. ஸோ பிரெயின்ல இந்த ஃப்ரீ ரேடிக்கல் மீடியேட்டட் இன்ஜுரி வராம இது பண்ற என்சைம் தான் வந்து that is protect பண்ற enzyme the superoxide dismutase. Anybody knows superoxide dismutase இல்லனா brainல என்ன disease வரலாம்? Anybody can tell me? இப்போ yes, very good. That is amyotrophic lateral sclerosis. அதாவது brainல superoxide dismutase will be protecting the brain from free radical mediated injury. But in the superoxide dismutase deficient இருக்கும்போது that can lead on to amyotrophic lateral sclerosis. Important question. Okay. Then a very important and interesting question. Annexin 5 is a marker of. So annexin 5 is a marker for, please remember the students, it is a direct question. Apoptosis. Okay, apoptosis. So ஒரு செல் வந்து apoptosisல இருக்கு அப்படின்னா என்ன பண்ணுவீங்க? First நீங்க annexin 5 actually போடலாம். Then also some other stains can demonstrate apoptotic cells. So என்னென்ன stains ன்னு பாத்தீங்கன்னா fulgen stain, acridin orange, tunnel assay னு ஒரு assay இருக்கு. Okay, tunnel assay. So tunnel assay, yes. Annexin 5 actually hairy cell leukemia la annexin marker, but annexin 5 illa. Annexin 5 na specific இருக்கும்போது that is apoptosis தான். Okay. So actually பாத்தீங்கன்னா annexin, yes, I accept annexin is actually also a marker for this hairy cell leukemia, but annexin 5 னும்போது that is for apoptosis. Okay. Yes, that is annexin 1A. Very good, Absan. So tunnel assay, fulgen stain, acridin orange. இப்போ எப்படி ஒரு apoptosis வந்து the cell you can recognize பாத்தீங்கன்னா apoptosis அப்ப the cell size will be shrunken. செல்லோட size சுருங்கி இருக்கும். Nucleus, chromatin, everything will be very much condensed. Yes, மணிகண்டன், it is phosphatidylserine serine only. The nucleus size எல்லாமே வந்து condensed இருக்கும். But ஆனா necrosis அப்ப the cell size will be swollen. Which one will have inflammation? Necrosis or apoptosis? எதுல inflammation இருக்கும், எதுல inflammation இருக்காது? Very important difference between necrosis and apoptosis. Which one will have inflammation? Yes, necrosis will have inflammation. Apoptosis, there is no inflammation. இது ரொம்ப முக்கியமான பாயிண்ட். ஏன்னா செல் மெம்பரேன் வந்து இன்டாக்டா இருக்கும் apoptosisல, no inflammation. Okay, இன்னொரு பாயிண்ட் ஞாபகம் வச்சுக்கோங்க. Apoptosis electrophoresis பண்ணீங்கன்னா step ladder pattern will be there. Okay, electrophoresis, agar-gel electrophoresis la step ladder pattern will be there, and number necrosis la there will be smudging or smearing pattern. Okay, smudging pattern. Yes, very good, Afsar. Then the next question, serum amyloid associated protein is found in. So if a generalized amyloidosis causes, main important causes in pathina, 3 types of amyloid you will be remembering. Okay, va? AL, generalized amyloidosis. Amyloidosis na adu vandu oru proteinaceous material that is deposited in the body. இத நம்ம generalized amyloidosis all over the body பிரிக்கலாம், இல்ல localized ஒரு organல மட்டும் பிரிக்கலாம். AL na என்ன? Amyloid light chain. So AL type of amyloid pathina, multiple myeloma la you will be getting that. Chronic inflammatory states la you will be getting AA, that you also call it as SAA. Apna serum amyloid associated. இப்போ ஒரு tuberculosis இல்ல bronchiectasis, rheumatoid arthritis, இந்த மாதிரி ஒரு long standing chronic inflammation la, when there is lot of inflammatory proteins are there, that proteins when they are not degrade ஆகலனா அந்த proteins la will be deposited as amyloid. அத நாம SAA அப்படினோம், serum amyloid associated chronic inflammatory state. Alzheimer's disease la என்ன amyloid இருக்கும்? Alzheimer's disease la what is the type of amyloid? Yes, anybody? Alzheimer's la enna amyloid? A beta, very good. Alzheimer's la. Then patient who are in chronic renal failure undergoing hemodialysis, enna amyloid irukkalam? Yes, A beta 2 microglobulin, microglobulin. These are all the other questions. Okay, ஞாபகம் வச்சுக்கோங்க. amyloid special stain Congo red, நார்மலா பார்க்கும் மைக்ரோஸ்கோப்ல ரெட் கலர்ல இருக்கும். அதே polarized மைக்ரோஸ்கோப்ல பாத்தீங்கன்னா it will be giving apple green by refrigerants. Apple green by refrigerants. Okay. Nutmeg liver. Yes, nutmeg liver is seen in nutmeg liver na ennadu. What is the name for nutmeg liver actually? Nutmeg liver na that is called as CVC liver. CVC liver. That is chronic venous congestion. Chronic venous congestion. So please remember students. Yes, very good. Very good. Right heart failure. So CVC liver is seen in right heart failure. Please remember CVC liver, CVC spleen, everything is seen in right heart failure. Left-sided heart failure, you will be getting CVC. Left heart failure, CVC of which organ will be there? If the left heart is not pumping, very good. If the left heart is not pumping, then you will be having congestion in the lung. CVC lung. So CVC lung, when there is congestion of the blood is there, you will be getting heart failure cells. So CVC lung, heart failure cells. And CVC liver, you will be getting nutmeg liver. CVC spleen, any body you know? CVC spleen, any body you know? Name of the body in CVC spleen? GG body, what is that? Gamna-Gandhi body. Okay, Gamna-Gandhi body. You will be getting in CVC spleen. Okay. So you must be wondering, என்னடா இது MRB எக்ஸாம்ல வந்து ஒரு இமேஜ் பேஸ்ட் கொஸ்டின் இருக்குன்னு சொல்லிட்டு. ஸோ யூஸ்வலா இது வரைக்கும் MRBல இமேஜ் பேஸ்ட் கொஸ்டின் கேட்டதே இல்லை. Since in the time வந்து ஒரு computer based exam இருக்கிறதுனால there may be a remote possibility கேட்டாலும் கேட்கலாம். So far they have not asked. Okay, but just to be sensitized, ஒரு sensitization ஓட நம்ம போனா that will be okay. So that possibility of an image based question can also be there. So அதுக்காக 2 image based questions we have included. So let's see that a very easy one. 12-year-old boy presents with fever, cough, night sweats. So in the history, fever, cough, and night sweats. So, and also the enlarged lymph node, cervical lymph nodes, enlarged. So histopathology. Okay. We'll try to change it, Jagadish. Thank you for that. And which of the chemical mediators, I think the one word would have been left. The chemical mediators is most important in the pathogenesis of his lesion. The diagnosis, fever, cough, night sweats. Again, you will be making a diagnosis of tuberculosis. You will be making a diagnosis of tuberculosis with the night sweats. And image of the excised lymph node, in the மாதிரி ஒரு collection of the cells will be there. What is this collection called as? In the whole collection is called as granuloma. In the whole collection is called as granuloma. So granuloma la enna cells இருக்கும்னு பாத்தீங்கன்னா you will be getting in the மாதிரி elongated cells. Okay, in the மாதிரி elongated cells. See here, this is the typical elongated cell. So in the மாதிரி cells இருக்கும். So in the cells oda nucleus எப்படி இருக்கும்னு பாத்தீங்கன்னா slipper shaped nucleus. Okay, in the cell oda nucleus எப்படி இருக்கும்? Slipper shaped nucleus. So in the cell தான் நாம வந்து epithelioid histiocytes அப்படின்னு சொல்லுவோம். So epithelioid histiocytes எப்படி இருக்கும்? Slipper shaped nucleus ஓட இருக்கும். So epithelioid histiocytes சேர்ந்து they will try to engulf or kill the Mycobacterium tuberculosis. But Mycobacterium tuberculosis-ல உங்களுக்கு myconic acid இருக்கிறதுனால bacteria will not be eliminated by the immune mechanisms. So அங்க நிறைய soldiers, our immune cells are coming there to kill the bacteria, but everything goes in vain. Okay, so the macrophages activate. Okay, I'm not able to kill the enemy. So it will activate the CD4 T cells. So they will be releasing interferon gamma. Okay, so please remember, this is a very important mediator. Okay, interferon gamma. So you can remember interferon gamma, which is responsible for the granuloma, G for G. Okay, interferon gamma, yes. But the most important is the interferon gamma money. So interferon gamma for responsible for granuloma. Yes, what is the type of giant cell which you can see here? What is the type of giant cell you can see here? These giant cells are called as Langerhans. Okay, Langerhans giant cell. Remember, it is not Langerhans. Okay, Langerhans, that is antigen presenting cells. In the giant cells, typically a horseshoe shaped nucleus. So in the horseshoe shaped pattern nucleus, you are calling it as Langerhans type of giant cells. So in the structure, is called as a granuloma. So இன்னொரு கான்செப்ட் ஞாபகம் வச்சுக்கோங்க. இங்க பாத்தீங்கன்னா caseous necrosis இங்க இல்ல. Tuberculosis can present as both caseating and non-caseating granuloma. நமக்கு TB-னாலே caseous necrosis தான் ஞாபகத்துக்கு வரும். Yes, correct. Tuberculosis-ல caseous necrosis இருக்கும், caseous granuloma இருக்கும். But non-caseating granuloma is also possible in tuberculosis. In the concept question எப்படி frame பண்றாங்களோ அப்ப நீங்க you have to answer accordingly. Non-caseating granuloma, other examples can we recollect? Non-caseating granuloma என்னென்ன இருக்கலாம்? Yes, வேற எங்க கேள்விப்பட்டிருக்கீங்க non-caseating granuloma? Sarcoidosis, very good. Sarcoidosis, Crohn's disease, sarcoidosis, Crohn's disease, Hodgkin's lymphoma. Okay, so sarcoidosis, Crohn's disease, Hodgkin's lymphoma, even in TB also you can get non-caseating granuloma in the concept. Okay, so moving on to the next question. Correct sequence in the process of wound healing. Yes, wound healing patti first we have discussed in one question. Adavadhu a wound strength will never be 100% regained. Okay va? So appa enna sonna first ஒரு wound heal wound ஆன உடனே என்ன ஆகும், அந்த இடத்துல ஒரு fibrin clot formation will be there. Scab formation. Okay, fibrin clot. Very good, Kaushika. Correct answer. ஒரு scab formation will be there. அந்த scab வந்த உடனே அதாவது என்ன ஆகும்னா நிறைய செல்ஸ் எல்லாம் வந்து infiltrate ஆகும். I told you neutrophils and all the cells will be infiltrated. Infiltrate ஆன பிறகு என்ன ஆகும், the cells will be removing that scab and there will be a new tissue formation there, that is granulation tissue. Granulation tissueல என்னென்னலாம் இருக்கலாம், fibroblast வந்து collagen produce பண்ணலாம், macrophage இருக்கலாம். வேற important finding என்ன granulation tissueல, new blood vessels will be forming. Granulation tissue wound healing la new blood vessels will be forming and that process is called as angiogenesis. That process is called as angiogenesis. Neovascularization, angiogenesis, new vessel formation and neovascularization. So in the correct sequence. Okay, fibrin clot formation, cellular infiltration, angiogenesis. This is the correct step. You can expect a question from chemical carcinogenesis and direct question. This is vinyl chloride is associated with, yes, what do you think vinyl chloride is associated with? Yes, it is liver angiosarcoma. Liver angiosarcoma. So in a commonest chemical carcinogens, asbestosis can cause mesothelioma. Aflatoxin can cause that a biological carcinogenesis that can cause hepatocellular carcinoma. Benzene can cause leukemias. Okay, benzene can cause leukemias, especially AML. Benzidine can cause bladder cancer. Okay, benzidine can cause bladder cancer. So alkylating agents, so all these things can cause your leukemias also. So secondary cancer. So just in the concept, go through the table column which we discussed in the Southern Hour session, chemical carcinogenesis. All of the following are features of arterial thrombus except. So நமக்கு தெரியும் thrombus நாலே we have that triad, Virchow's triad. Virchow's triad ல என்னென்ன இருக்கலாம், endothelial injury, hypercoagulability, altered blood flow. Altered blood flow எப்படி இருக்கலாம், அது ஒரு turbulent blood flow ஆகவும் இருக்கலாம், இல்ல stasis ஆகவும் இருக்கலாம். So that is altered blood flow. இந்த மூணு சேர்ந்ததுதான் Virchow's triad. So அப்போ ஒரு thrombus formationக்கு definitely இந்த Virchow's triad will be there. So அப்போ endothelial injury, arterial thrombusல endothelial injury தான் commonest etiological agent. அதே venous sideல வந்து thrombus ஆகும்போது என்ன ஆகும்னா stasis, blood stasis. You would have heard இப்ப deep vein thrombus, ஒரு patient long standing bedridden இருந்தாங்கன்னா they will have deep vein thrombus, அங்க stasis. But arterial thrombusல endothelial injury is an important etiological factor. Lines of Zahn. Lines of Zahn என்ன ஒரு thrombusல alternating dark and pale areas. Alternating dark and pale areas இருக்கிறதெல்லாம் lines of Zahn அப்படின்னுவோம். இந்த dark areasல என்ன இருக்கும்னு பாத்தீங்கன்னா நிறைய RBCs இருக்கும். நிறைய RBCs இருக்கும். And இந்த pale areaல you will be having platelets and fibrin. Platelets and fibrin. So இந்த மாதிரி alternative. So remember, pale for platelets. Okay, pale area, platelets. So lines of Zahn will be present in your arterial thrombus, and you have both dark areas as well as pale areas. Platelets, fibrin, pale area, and this red areas RBC. So ரெண்டுமே இருந்தால் கூட this will be more of having arterial thrombus will be having more of platelet and fibrin. So அதனால pale, it is also called as pale thrombi. Arterial thrombi is also called as pale thrombi. But venous thrombi la nariya RBCs irukum. Venous thrombi la nariya RBCs irukum, dark irukum. So this option is also right. Innonu mukkiyamaana concept, please remember, venous thrombi will be loosely attached to the wall. Ipa deep leg veins la vandu thrombus agudilla, deep leg veins, venous thrombi. Those thrombi only loosely attached to the vessel wall. அது லூசா அட்டாச் ஆயிருக்க தொட்டு தான் the commonest நம்ம என்ன பண்ணுவோம், deep vein thrombosis, embolism, pulmonary embolism போகுதுன்னு we would have read. So அப்ப the deep leg vein thrombus are loosely attached to the vessel wall, so easily அது வந்து embolism போகலாம். But arterial thrombi are tightly attached, okay, firmly adherent to the vessel wall. So இதுதான் wrong option. இதுதான் wrong option. Okay. Which one of the listed changes correctly describes the pathophysiology involved in the production of pulmonary edema in patients with congestive heart failure? So you know the mechanism of edema formation. உங்களுக்கு தெரியும் ரெண்டு pressure முக்கியம். ஒன்னு வந்து hydrostatic pressure and இன்னொன்னு வந்து osmotic pressure. Okay, இன்னொன்னு வந்து osmotic pressure. So normally என்ன இருக்கும்னு பாத்தீங்கன்னா hydrostatic pressure will tend to push the fluid away. Osmotic pressure will tend to pull the fluid in. Osmotic pressure because of plasma proteins. இங்க pulmonary edema-ல என்ன ஆகும் அப்படின்னு சொல்லிட்டு பாத்தீங்கன்னா there will be more fluid that will be accumulating in the lung. லங்ல pulmonary edema, lung vesselsல எல்லாம் நிறைய fluid வந்து அதிகமா இருக்கும். So நிறைய fluid வந்து அதிகமா இருக்கிறதுனால the fluid content inside the vessel wall is very high. So அப்ப அந்த tension அதிகமாகிறதுனால the hydrostatic pressure will be more, and the increased hydrostatic pressure will be pushing the fluid away. That is edema formation. So pulmonary edema why there is actually production of pulmonary edema in congestive heart failure அப்படின்னு சொல்லிட்டு பாத்தீங்கன்னா congestive heart failure, heart will not pump properly. Heart will not pump properly. So heart அங்க pump பண்ணல என்ன ஆகும், left heart failure ஆகும்போது என்ன ஆகும், there will be backlog of blood into the lung. So அப்ப lungல there will be congestion. அப்ப lung vesselsல when there is excess fluid, that will be pushing the fluid away and more fluid collection in the lung will be there. அப்ப pulmonary edema, why it happens in congestive heart failure because of increased hydrostatic pressure அதிகமாகும், increased hydrostatic pressure. All of the following are true about von Willebrand's disease except von Willebrand's disease. அது முன்னாடி we have to know what is a von Willebrand factor. Everybody knows von Willebrand factorக்கு ரெண்டு function இருக்கு. ஒன்னு வந்து it helps in platelet adhesion. Von Willebrand factor helps in platelet adhesion. Von Willebrand factor acts as a carrier protein for factor 8. Von Willebrand factor helps in platelet adhesion. It also helps as a carrier protein for factor 8. So அப்ப von Willebrand diseaseல என்ன ஆகும்னு பாத்தீங்கன்னா von Willebrand factor levels கம்மியா இருக்கும். அப்ப platelets adhesion ஆகாது. So platelets adhesion ஆகலனா என்ன ஆகும், bleeding time will be prolonged. Yes, bleeding time will be prolonged. Okay. Factor 8 levels இருக்காது, நார்மலா இருக்காது. ஏன்னா factor 8 நார்மலா கேரி பண்ணிக்கிறதுக்கு 1 milligram factor is needed. So factor 1 milligram factor இல்லன்னும் போது factor 8 levels கம்மியா இருக்கும். factor 8 levels கம்மியா இருந்துச்சுன்னா which time will be prolonged? PT APTT? Please remember APTT factor 8 வந்து உங்களுக்கு intrinsic pathwayல தான் வருது. factor 8 comes in the intrinsic pathway. Intrinsic pathway measure பண்ற test வந்து APTT. So PT will not be prolonged in von Willebrand disease. PT prothrombin time வந்து extrinsic pathway தான் டெஸ்ட் பண்ணுது. APTT தான் வந்து intrinsic pathway டெஸ்ட் பண்ணுது. So PT will be normal. Only APTT will be prolonged in von Willebrand disease. Okay. And there are 3 types of von Willebrand disease. One type 1 and 3 are quantitative defect. Okay, quantitative defect. Quantity கம்மியா இருக்கும். But type 2 வந்து qualitative defect. Qualitative defect போது that is the level பாத்தீங்கன்னா 1 Willebrand level will be normal, but its function is abnormal. That is qualitative defect. Type 1 and 3 are quantitative defect. This is right. Platelet count will be normal. There is nothing to do with the platelet count. Platelet count will be normal in von Willebrand disease. Only the platelet function is defective. Type 3 is inherited as autosomal recessive. மற்றபடி type 1 and 2 வந்து autosomal dominant. So இங்க பாத்தீங்கன்னா இந்த ஆப்ஷன் தான் wrong option. Popcorn cells are seen in which variety of Hodgkin's lymphoma? Yes, popcorn cells in the Hodgkin's lymphoma la இருக்கும். Yes, all of you would have got this question right. Yes, it is nodular lymphocyte predominant. Nodular lymphocyte predominant. Nodular sclerosis. Nodular sclerosis la என்ன type of RS cells will be the nodular sclerosis? Lacunar RS cells. Lacunar RS cells. Lacunar RS cells. Yes, all of you will be knowing about the morphology of your Reed-Sternberg cell. Okay, Reed-Sternberg cell. Reed-Sternberg cells will have a typical Owl's-eye-like appearance. Owl's-eye-like appearance. Okay, Owl's-eye-like appearance with a prominent eosinophilic nucleoli. Okay. Moving on to the next question. Which of the red cell abnormalities is most indicative of hemolysis? Hemolysis ஆகிறதுக்கு which one is most indicative? Yes, you are very good. Most of you have said that schistocytes. Yes, schistocytes. If in the disseminated intravascular coagulation or in the hemolytic uremic syndrome, in the conditions when there is excessive hemolysis, which is occurring, excessive hemolysis occurring ஆகும்போது peripheral smear you will be seeing this fragmented RBCs. This kind of fragmented RBCs. In the fragmented RBCs, we are calling it as schistocytes. Schistocytes. Target cells எங்க இருக்கும்? Target cells, most commonly it will be seen in thalassemia. Target cells, thalassemia. Even in iron deficiency anemia also it will be there, but most commonly seen in thalassemia. Acanthocytes, எங்க இருக்கலாம்? Acanthocytes. What is the other name for acanthocytes? Spur cells. Spur cells. So A beta lipoproteinemia. A beta lipoproteinemia. Myelofibrosis, you will be seeing teardrop cells, Prakadishwar. Okay, myelofibrosis, you will be seeing teardrop cells. Acanthocytes in liver disease, you will be getting A beta lipoproteinemia. And basophilic stippling, main வந்து பாத்தீங்கன்னா lead poisoning இருக்கும். Lead poisoning, yes, very good, Prakadishwar. Lead poisoning. Sometimes even in megaloblastic anemia and also in thalassemia also you can get this basophilic stippling. First one, think of lead poisoning. Okay. True regarding anemia of chronic disease or all except. Okay, one of the again important repeat topic is anemia of chronic disease. So anemia of chronic disease பாத்தீங்கன்னா வந்து interleukin 6 வந்து அதிகமா இருக்கும். Increased levels of hepcidin அதிகமா இருக்கும். So anemia of chronic disease, very important point to differentiate anemia of chronic disease plus with iron deficiency anemia. Two important parameters I used to always stress. Please remember, in anemia of chronic disease, total iron binding capacity will be decreased. In anemia of chronic disease, total iron binding capacity will be decreased. In iron deficiency anemia, total iron binding capacity will be increased. Okay, increased. Another important point in to differentiate anemia of chronic disease and iron deficiency anemia, anemia of chronic disease serum ferritin levels should be increased. Okay, serum ferritin levels should be not in anemia of chronic disease, it is increased. Whereas in iron deficiency anemia serum ferritin levels kammiyaagum. Anemia of chronic disease serum ferritin levels should be increased. Anemia of chronic disease serum ferritin levels should be increased. And also increased macrophages. Okay, increased macrophages in the iron in the marrow. Obviously, serum iron levels also will be less. Which what the following is not seen in PNH is paroxysmal nocturnal hemoglobinuria. In the night time, actually the patient will be hemolysis. So history the passing of early morning dark colored urine. The history will be there. Okay, PNH. So triad enna class aplastic anemia, venous thrombosis, intravascular hemolysis. Remember, only acquired cause of this PNH, intravascular hemolysis is PNH. Okay, please remember PNH in the moon triad symptoms. Okay, aplastic anemia, venous thrombosis, and intravascular hemolysis. Okay, so please remember, actually, in PNH. Actually, the lab scores, all this thing can be there. Actually, it should be increased lab score. This was wrongly given. So actually, in PNH, this was wrongly typed. In decreased lab scores can be seen in PNH, CML, and MDS. Actually, the option was wrongly typed. It should be an increased lab scores. Okay, increased lab score. This is the wrong thing. That is not seen in PNH. Increased in PNH, CML, and MDS, the lab scores will be decreased. Splenomegaly is usually found in all cases of hemolytic anemia of many years duration except. So, if splenomegaly thalassemia massive splenomegaly, thalassemia and hereditary spherocytosis splenomegaly irukum. The triad one of the important feature splenomegaly. Hereditary spherocytosis splenectomy is usually done. Splenectomy is usually the treatment. First one of the treatment they will try. G6PD deficiency there will be splenomegaly will be there. But sickle cell anemia repeated infarction, the sickle cells will occlude the splenic vessels. So repeated the splenic vessels, sickle cells occlude there will be repeated attacks of ischemia, infarct. So spleen will undergo fibrosis. So usually later stages of sickle cell anemia you will be getting spleen area, you will be getting only a splenic scar tissue only will be there. So the spleen would have gone for autosplenectomy. So in sickle cell anemia, you can remember autosplenectomy. Autosplenectomy will be there. Okay, autosplenectomy will be there. Response to iron in iron deficiency anemia is denoted by. Okay, so iron deficiency anemia the important indicator body iron கொடுத்து response ஆகுது, the hematopoiesis starts occurring. அதுக்கு important indication என்ன அப்படின்னு சொல்லிட்டு reticulocytosis. நார்மலா என்ன ஆகும்னு there will be increased retic count after iron therapy. எந்த டேஸ்ல யூசுவலா இருக்கும் அப்படின்னு சொல்லிட்டு mainly in the 5 to 10 days. Okay, iron therapy start பண்ண 5 to 10 days there will be increase in the reticulocyte count. Increase in the reticulocyte count. Okay, so reticulocytosis, it is a response to iron in iron deficiency anemia. Reticulocyte count அதிகமாகணும். Normal retic count எவ்வளோ? 0.5 to 2%. Normal retic count எவ்வளோ? 0.5 to 2%. Yes. And what is the special stain for reticulocyte? What is the special stain for reticulocyte? Supravital stain, new methylene blue, brilliant crescent blue, new methylene blue. Special stain for reticulocyte. Special stain for reticulocyte. Okay. Now see this. A 65-year-old male complains of altered bowel habits for the past 3 months. Colonoscopy was done and it revealed a mass in the sigmoid colon. The biopsy was reported as moderately differentiated adenocarcinoma. His complete blood count revealed a hemoglobin 9.2 gram per deciliter and MCV of 69 femtoliters. Which of the following is the most expected finding in this patient? Yes, everything, the reticulocyte is the main thing. Reticulocyte, actually increase in the reticulocyte only, the good response will be there. If they are not specified anything, reticulocyte will be the best option. And see in this question, altered bowel habits, and they have made a diagnosis here. The patient has done for a colonoscopy and they have diagnosed this as a moderately differentiated adenocarcinoma. So the patient is having carcinoma colon. So carcinoma colon, elderly male, the presenting feature, please remember, an elderly male presenting with an iron deficiency anemia, you have to rule out colonic cancer. That is an important differential. Elderly male presenting with an iron deficiency anemia, you have to rule out colonic cancer. Okay, you can see here hemoglobin is less and also MCV is 69 femtoliter, microcytic. So microcytic MCV, the cells are microcytic and hemoglobin is 9.2. Okay, so this is a straightforward a case of iron deficiency anemia because the patient is losing the blood. Okay, there will be melena will be there. Patient will be having bleeding per rectum. So every day he will be losing the blood. So when there is a constant blood loss, iron deficiency anemia. So ipodan paathom iron deficiency anemia la serum ferritin levels kammiya irukum, iron levels kammiya irukum, total iron binding capacity will be increased. So in the concept romba mukkiyam, definitely anemia of chronic disease illa iron deficiency anemia la irundhu edavadhu oru question in the parameters MRB la edipakalam. Idhe same thing concept, NEET, INCT ella exam liyum idu vandu one of the favorite